Alright guys, hi guys, good evening, good evening. I hope everybody is able to see me, hear me, right? So today is our last lecture on the hernia. So the next week we'll be starting with a new series or a new subset of topic. So we'll conclude all the hernias which are left behind. So we have started with the ventral one. So today's opening topic I would like to start is going to be with the Spigelian hernia. Now, a lot of important concepts goes behind the Spigelian hernia, so we'll just quickly go across it. So we're talking about the Spigelian hernia. So first of all, what is a Spigelian hernia? It is a hernia. So we say Spigelian hernia. It is a hernia through a defect in Spigelian fascia in the Spigelian fascia, right? So it is a defect in the Spigelian fascia, and that defect in the Spigelian fascia is resulting in Spigelian hernia. Now the immediate question is, what is this Spigelian fascia? What is this Spigelian fascia? Now, to be very honest, when we say Spigelian fascia, it is nothing but aponeurosis. It is nothing but the aponeurosis of the transverse abdominis muscle. Of the transverse abdominis muscle. Now, what do you mean by this, right? So to understand the whole concept of it, we have to revisit our abdominal wall, and we have our abdominal wall, which is, this is your Xiphi sternum, and let's say this happens to be your pubic symphysis, right? So we'll take this as the pubic symphysis, and that is a Xiphi sternum. In between these two, you have your rectus abdominis muscle. So this is the orientation of the rectus abdominis muscle. Now we all know the rectus abdominis muscle have, this is the umbilicus, let's say. There are two borders, that is the medial and the lateral border. Just for the sake of understanding, this is the representation of the rectus abdominis muscle. This is the representation of the rectus abdominis muscle. Now on the lateral border of the rectus abdominis muscle, you have the lateral abdominal wall muscles also. So when you look at the lateral abdominal wall muscles, they occupy in this particular fashion. So this is your lateral abdominal wall muscle. So if you look at the representation, just for the sake of understanding, this is how the lateral abdominal wall muscles would look like. So this is the orientation of the lateral abdominal wall muscles. Let it be an external oblique, the internal oblique, or the transverse abdominis muscle. So this is your lateral abdominal wall muscles. Now what I want you to observe is, especially below the level of umbilicus, when you go and look at below the level of umbilicus, there is this area where you can see there is a deficit of muscle, right? So if you take this a level of umbilicus, from here you can see this is the lateral border of the rectus abdominis muscle, this is your lateral abdominal wall muscle, and there is this area which is not covered by any muscle. So basically a small gap there. Now that small gap is actually filled up with your aponeurosis of your transverse abdominis, right? So there is the only structure that exists here is the aponeurosis of your rectus, or sorry, transverse abdominis muscle. Now this aponeurosis which is present of the transverse abdominis muscle, this is what we call it as the Spigelian fascia. This is what we call it as the Spigelian fascia. In true words, the Spigelian fascia is nothing but the aponeurotic tissue of the transverse abdominis muscle, right? So you have noticed that this is the lateral abdominal wall muscle which has come across here, and this is how the lateral abdominal wall muscle is running, right? And in the medial side, you have the rectus abdominis muscle which is going to be running on the medial aspect. Okay. Now, in between these two, this is what we call it as the Spigelian fascia. This is what we call it as the Spigelian fascia. So the Spigelian fascia is nothing but the aponeurosis. It is nothing but the aponeurosis of the transverse abdominis muscle. So whenever there is any defect through this, obviously it is going to result into a herniation. Now, but when you look at the lateral aspect, I'm just going to show you the lateral aspect. This happens to be your xiphisternum, and this is your pubic symphysis, or I can say the junction. And let's say this happens to be your rectus abdominis muscle. I'm showing you the lateral view, right? So this is how the rectus abdominis muscle is going to look like. So this is the rectus abdominis muscle which is present. Now we have the two rectus sheath that everybody knows it. One is your anterior rectus sheath, which is going to be covering the entire aspect of the rectus abdominis muscle. Now if you take this as the representation of the skin, and let's say this happens to be umbilicus, and this is going across here, right? Then there is a posterior rectus sheath which goes all the way to that of the umbilicus. 2 centimeters below the umbilicus, this is going to pierce the rectus abdominis wall muscle and then becomes anterior. There is a very common misconcept that because you can see that this area of the rectus abdominis muscle, right, this area of the rectus abdominis muscle which is posterior, you're saying there is no posterior rectus sheath, so obviously this is weak. So if the hernia has to occur, it will occur from this region, because the lateral wall, I mean say the posterior wall of the rectus abdominis muscle does not have a rectus sheath, so that makes it to be weaker. To contrary to that belief, whatever Spigelian hernia that we see between the umbilicus and this line which is piercing is what we call as arcuate line. So the most common site for Spigelian hernia is below the umbilicus. It is below the umbilicus and above the arcuate line. Above the arcuate line. It is below the umbilicus. It is below the umbilicus and above the arcuate line. Now this is what we call it as the arcuate line. This line is what we call it as the arcuate line, right? So this is the umbilicus, and this happens to be your arcuate line. So if you look at the whole picture again, just to get everything in the same wrap up, if I give you the entire abdominal walls picture, this is how the abdominal wall will be depicted. This is how the abdominal wall will be depicted. This is the umbilicus. Let's say this happens to be the rectus abdominis muscle. Let's say this happens to be the rectus abdominis muscle, which is present dead in the center. Then you have the lateral abdominal wall muscles. So let's say this happens to be the lateral abdominal wall muscles, which are going like this. This is your lateral abdominal wall muscles. It's going to go like this. So this is the line which is going to depict the umbilical line. So this is the umbilicus, right? Then we have the two rectus sheath, which we have already dealt. For the sake of understanding, I'll just say it. This happens to be the anterior rectus sheath, which is going to be through and through the entire rectus abdominis wall muscle. And behind this you have the posterior rectus sheath. So let's say this happens to be the posterior rectus sheath, which is now becoming anterior from this point, right? On the either side you see this is the posterior rectus sheath, which is becoming anterior. Going to become anterior, right? So this is already your anterior rectus sheath, which is present here. So this is the anterior rectus sheath which is already present, and the posterior rectus sheath is becoming anterior at this point, right? So the point where it is becoming anterior is what we call it as the arcuate line. This is what we call it as the arcuate line, and this is your umbilicus, right? So no confusion at all. Just for the sake of understanding, this is your rectus abdominis muscle. This happens to be your rectus abdominis muscle. Now, between the lateral abdominal wall and the rectus abdominis, as I told you, there is a fascia which is going to be present, and this is your Spigelian fascia. This happens to be your Spigelian fascia, right? So this happens to be the Spigelian fascia that is present across here. So let's say this happens to be the Spigelian fascia. Now you need to understand the Spigelian fascia is the posterior most. ठीक है, सबसे पीछे है वो. ठीक है, it is the posterior most, and you see this is your anterior rectus sheath, which is on the anterior surface, which is covering the rectus abdominis muscle, right? Now, above the Spigelian fascia, you have the external oblique aponeurosis, you have the internal oblique aponeurosis, everything is there, but the fascia transversalis is behind your Spigelian fascia. So again, not to have any confusion, I'm repeating again and again, your Spigelian fascia is nothing but the aponeurosis of your transverse abdominis muscle. It is the aponeurosis of your transverse abdominis muscle. Okay? Now, usually when the hernia arises, the most common site it is going to arise is at this point. Right? At this point. Right? So usually most common site, the most common site for Spigelian hernia, for the Spigelian hernia, is going to be at this particular site, that is below the level of umbilicus, above the level of arcuate line. Okay? Now these lines which are present, no, I hope everybody is clear. This is what we call it as the linea semilunaris, and right in the center that you have, this is what we call it as the linea alba. Now obviously Spigelian hernia swelling is going to present along the line of linea semilunaris. Nothing more than that you need to worry about it. Okay. So the hernia is going to be at this particular site. The patient will have a swelling. So when you talk about the clinical presentation, let's quickly wrap it up. Now clinical presentation of the Spigelian hernias, you will see it is seen equally in both males and females. It is more common in elderly patients. It is more common in elderly patients. Usually, see again, presenting with swelling is not a very common presentation that you will see, but you will see that it is going to be presented with pain at least, right? So if the swelling is going to present, the swelling will usually be present along the linea semilunaris, below the level of umbilicus, below the level of umbilicus. But Spigelian hernia presenting as swelling is an uncommon finding. It is usually an uncommon finding. More importantly, they present to you as pain. They present to you as pain in that region, right? So usually they are going to present to you as pain rather than in terms of your swelling. Now this pain can be associated with the bowel getting trapped into it. So there will be presence of intermittent obstruction and intermittent obstruction, right? Now usually the diagnosis has to be done for Spigelian hernia. You have to resort to CT. So CT, or I can say CCT of the abdomen. CCT abdomen is the investigation of choice. You can also do the ultrasound of the abdomen to look for the same component. But if I say what is the management, the management here is going to be IPOM, which we have discussed at yesterday's lecture. That is your intraperitoneal onlay mesh repair. It is an intraperitoneal onlay mesh repair is what we call it as. the eye palm. So this is all that in the context Spigelian hernia. Remember, for Spigelian hernia, you don't need to really worry about the presentation part and all. You should know what is the usual site from where it is going to present, and then how or what is Spigelian fascia. The more important concept here is what is Spigelian fascia. If you're clear with the concept of Spigelian fascia, you don't need to worry about it at all, right? The last nail in the coffin in the hernias is going to be our lumbar hernia. So we'll be talking about the lumbar hernia. Now, lumbar hernias are actually a very uncommon hernias, right? So we need to understand, for the lumbar hernias, there are two defects which are going to be present. One, it can arise from a superior lumbar triangle. Another one, it can arise from an inferior lumbar triangle. So I want you to understand both the triangles in detail, that where do you get a superior lumbar triangle? A superior lumbar triangle defect, and the inferior lumbar triangle, and the inferior lumbar triangle. So there are two triangles from where the lumbar hernias can arise. One is your superior lumbar triangle, another one is your inferior lumbar triangle. We should know the boundaries of both superior as well as the inferior lumbar triangle. Now, for the sake of understanding, your superior lumbar triangle is also called as the triangle of Greenfield. Is also called as the triangle of Greenfield. And the inferior lumbar triangle is also called as the triangle of Petit. Is also called as the triangle of Petit. So there are two triangles. One is triangle of Greenfield, another one is triangle of Petit. Now let's understand, where do you find this superior or the inferior lumbar triangles. Let's imagine that this is the back of the patient that I'm depicting to you. So let's see, this is the back of the patient that we are depicting it to you. This is the gluteal region, and this is going to be in the center. Because I have to show two triangles, we'll have two guys here. Okay. Now, just for the sake of understanding, let's say this happens to be the midline, which are going to be present, right? Now, there are few pointers that we'll do. Number one is going to be the iliac crest. So this is where the iliac crest is present. On the either side, this we have made as iliac crest. Now, on the superior aspect, you have the ribs. So let's say this will make it as the 12th rib, which is present here. So we'll use a different color for ribs. Let's say this is the 12th rib that is present. So in the context of the component, this is the 12th rib, right? So before we move with further details, I'll just mark it down. This is the 12th rib that we have marked it. And this inferior one is your iliac crest. This is your iliac crest. Now, on the medial aspect, you have the muscles which are called as the paraspinal muscles. So the muscle which is going to be depicted here are going to be set of your paraspinal muscles, right? So these are your paraspinal muscles which are present. Now, in the same context, there's another muscle which is going to be coming from the posterior aspect. That is going to be your inferior oblique muscles. Sorry, so you have, okay, abdominal muscles, you have the external oblique, internal oblique, transverse abdominis. It is the internal oblique muscle which is going to arch out and they are going to go like this. So this is your internal oblique muscles, right? So this entire coefficient is of internal oblique muscles which are going like this, right? So this is the orientation of your internal oblique muscles, right? So between the internal oblique muscles, the paraspinal muscles and the 12th rib, you see there is a triangular area. There's this triangular area which has now been created, and this is what we call it as the superior lumbar triangle. As you can see, there is no muscle, there's nothing guarding it. So if the hernia pops out through this, right? If a hernia pops out through this, this is what we call it as the superior lumbar hernia. It is a superior lumbar hernia, right? For the sake of understanding, let's quickly, so these are your paraspinal muscles. So you get a grip of it. So I'm just going to mark it down. So these are your paraspinal muscles. and this is your internal oblique muscles. Your internal oblique muscles, right? So between the 12th rib, the paraspinal muscle and internal oblique, you have your superior lumbar triangle. Now the same activity, we are going to repeat it here. So this happens to be the midline. This happens to be the midline. This is the 12th rib that we have. Now we'll not be interested in 12th rib. So this is the iliac crest that you have. The same thing, but this time the concept is going to be slightly different here. So here you see there is a muscle that is going. This is your latissimus dorsi muscle, which is going to be running like this, right? So this is the orientation of your latissimus dorsi muscle, right? So it goes and adheres here. So this is how your latissimus dorsi muscle is going to grip across, right? So this is your latissimus dorsi muscle. This is your latissimus dorsi muscle, which is present here, right? Now then you have the external oblique muscle. So you see the external oblique muscles orientation is going to be like this. So this is how you see the external oblique muscle is arching, right? Now between the latissimus dorsi, the external oblique muscle and the iliac crest, you see there is a triangle that is created. This is what we call it as the inferior lumbar triangle. So between your latissimus dorsi, your external oblique muscle and the iliac crest, right? So quite simple. We'll just quickly label them so that you understand it better. I think I should label them in this particular. I'll just move a bit so you get the labeling part correct. So this happens to be the iliac crest. This is going to be the iliac crest. This happens to be the external oblique muscle. This happens to be your latissimus dorsi. So between the latissimus dorsi muscle, the external oblique muscle and the iliac crest, this is your inferior lumbar triangle and the hernia will pop out from here, right? So this is your inferior lumbar triangle. So two important concepts that I've just given you with respect to the lumbar hernias, that you should know what are the two defects from where it can arise. Number one is your superior lumbar triangle, another one is your inferior lumbar triangle, and both of them are equally important, right? Now, if they ask you, usually to make your life difficult, whenever they ask you any triangles, no, they will ask you what is your superior boundary, what is your medial one, what is your lateral one, right? So this is the one boundary and this is your inferior lumbar triangle, this is your another boundary, right? So we'll just simply label them. This is the superior boundary, this is your medial boundary, this is your lateral boundary. This is going to be your lateral boundary, this is your medial boundary, this is your inferior boundary, right? So superior boundary in your superior lumbar triangle, it is formed by the 12th rib. Medial boundary, it is formed by the paraspinal muscles. And the lateral boundary, it is formed by the internal oblique muscles. It's formed by the internal oblique muscles. Same way, inferior lumbar triangle, the medial boundary, it is formed by the latissimus dorsi. It is the latissimus dorsi muscle. The lateral boundary is formed by the external oblique muscle. Inferiorly, it is formed by the iliac crest. It is formed by the iliac crest. Clear? Okay, I didn't see you guys join. I thought because Lokesh, we have, okay. Lokesh says it is not uploaded. This is the entire notes of the hernia which is there. Okay, so from the day one of our lecture, this have been following. See, every time we do it, like we have labeled as lecture number 41, you will have the lecture for 41. There's lecture number 42, which have labeled it. Then you have, this will be lecture number 43. This will be lecture number 43 that is labeled and sent. Then today is lecture number 44. Right. So all these lectures are being uploaded. Don't worry about it. We will put it across. See, sometimes the notes may not be uploaded on the same day or the same week, because some edits has to go with the notes. Where I'm giving a real-time images, they will add that images, a little bit of info will be there, and then they'll post it there. I'll ask them to do it as soon as possible. In fact, I'll ask them to upload it today itself. Okay? So don't worry about it. So this is your superior lumbar triangles and the inferior lumbar triangles. Okay? Clear, guys? Right? Ye paraspinal muscles, no, sometimes they can use the word examples like sacrospinalis. They can use the word as sacrospinalis muscles. Okay? So don't worry about it. Now, usually when they present to you, again, lumbar hernias are not that quite commonly available or seen ones. So you will see same as a reducible swelling. They'll present to you as reducible swelling from superior or the inferior lumbar triangles or the inferior lumbar triangles. They will have the same presentation. They are usually, see, the defects are large, so they will have a wide mouth. They'll be having a wide segment, so they have very low risk for strangulation. So I'm not worried about strangulation per se. Again, here you will see presence of cough impulse to be positive. They have the cough impulse to be positive. They have a wide defect. Now, because they have a wide defect, they have very low risk for strangulation. They have the low risk for strangulation. The investigation of choice here is going to be a CECT abdomen. I need to see the size of the defect and then go and repair it. So the concept is same. Open the hernia, like you incise the skin, dissect the sac, open the sac, reduce the content, put the sac back, and then put the mesh and repair the defect. The only thing that you need to remember here, the name of the surgery, the management here is going to be surgery, and that is what we call it as the Daud-Ponka surgery. So basic steps are still the same. Nothing changes. In Daud-Ponka surgery, you're giving an incision over the swelling. You're reducing, you're identifying the sac, opening the sac, reducing the content, removing the excessive sac or repositioning it back, putting a mesh and repairing it back. That's what we do in the Daud-Ponka surgery also, just for the sake of the name, to give you a little bit of ooh-ah and all. That is what has been put across here. Okay. So this is going to be your lumbar hernias. Then there's something called as the parastomal hernias. We'll just quickly go ahead. Parastomal hernias. Now, parastomal hernia is a hernia around a stoma. So we define this as hernia arising from a stoma site. Now, we'll be dealing a great bit of detail when you talk about the GIT, about the stomas. So this is how we're going to talk about it. If this is the abdomen, and let's say if this is the umbilicus, I can divide the abdomen into 4 different quadrants, right? I can divide the abdomen into 4 different quadrants, taking the umbilicus as the center. If you have an opening of the bowel here, this is what we call it as colostomy. If you have the opening of the bowel here, this is what we call it as ileostomies, right? Now, usually these are the bowel loops which are going to be opened. So just to get a perspective out, if this is the colon that we are talking about, this is how the colon would be opened. Now, if the colon is opened onto a skin surface as a diversion, this is what we call as colostomy. On the other hand, if you are opening the ileum, so this is a small bowel that we're trying to talk about it. if you open the small bowel onto the skin, this is what we call it as ileostomy. Colostomy is for the large bowel and ileostomy is for the small bowel, right? Now, whenever you open this area from where you have opened, this is opening onto the skin surface, so it is creating some amount of weakness. So what can happen is a part of the bowel, it is usually the small bowel, that can invaginate through this, right? Or the small bowel can invaginate through this and it can pop out. Now, if the small bowel invaginates through this and pops out on the outer surface, this is what we call it as parastomal hernias. Problem here is it is anticipated in 50% of the patients. So 50% of the patients with stoma will develop parastomal hernias. Will develop a parastomal hernias. The problem here is if they develop parastomal hernias, as the bowel continues to protrude out, it can get obstructed. It is going to cause more problem. It is going to cause pain also. But more importantly, we put a bag here. Now, bag is going to fit into these colostomy or ileostomy sites. Now, because the bowel is protruding, it won't allow that device to fit properly. If it is not going to fit properly, then there will be a lot of leak is going to happen. Skin excoriations will occur, and all that fecal matter is continually pouring out, hampering the quality of life. So parastomal hernias has to be repaired. If you ask me what is the ideal management for parastomal hernias, the ideal management for the parastomal hernias, it is to do a stoma reversal. Now, stoma reversal is basically to close the stoma back, right? So maintain the continuity. Go and let's say there's a rectal stump which is present here. You see, this is the rectal stump which is closed, right? So this is the stump which is closed here. So ideally, when you talk about what should be done, ideally you should take this and reattach it. But in every case, it is not possible. If a patient has undergone an API, that is abdominoperineal resection, we cannot do a stoma reversal. So ideally, stoma reversal is to be done, but this is usually not possible, right? So what are the options that you have in order to treat your stoma components, right? Or this parastomal hernias, how would you like to treat it, right? So when we talk about the stoma repairs, or I can say the parastomal hernia repairs, there are three techniques that I would like to talk about. Number one is your sugar baker. Another one is your keyhole surgery. Another one is resighting. Another one is the resighting with mesh reinforcement. Now, what do you mean by this? Sorry to disturb, so please change the background to white color and upload it. It will help a lot. But if I put a white background, there's a lot of light reflection which is going onto the board. So on a white background, if I write with any other color, it is not getting properly visualized, right? So that's the difficulty we had. Initially started with a white background only, लेकिन उसमें वही दिक्कत हो गया था कि white background से ना जो लिख रहे थे वो ढंग से दिख नहीं रहा था. तो black में क्या contrast better है. That's the reason we're using black. I also love white pages, but क्या करें, ठीक है. So let's understand what is sugar baker, what is keyhole, what is resighting, or with the mesh reinforcement. Now what we do is, in a sugar baker's technique is, let's say that this is the abdominal wall, right? So this is the abdominal wall. This is the abdominal wall. Let's say this happens to be the subcutaneous fat. And let's say this is the muscular layer that we have. This is the muscle that we have. And then you have your fascia transversalis, which is here. And then you have your peritoneum, which is present here. Right? So everything has been same. We have not changed anything. The concept of abdominal wall is being continued across. what are we going to do with this? Wait. Okay. So in a sugar baker, so let's say this is the colostomy. So what you're doing in a colostomy is, in a colostomy, you are going to open up here so that the stoma is going to be present here. So this is the passage for stoma. Let's say this is the bowel that is being opened out. This is the stoma that has been opened out, right? So the bowel is being presented across here. So what sugar baker does is, it says let's reinforce this. How does we reinforce this is, we are going to put this along with a mesh and allow it to go. So what we have done is, here we have placed a mesh. So what I'm doing is, I'm putting a mesh under the peritoneum going around this, right? So I am covering this part. It goes with the mesh and we see the bowel is being laid across here. So this mesh which you have put is now anchoring the bowel with the abdominal wall. So what is going to happen? It is covering all the area, not allowing any other bowel to pop out. This is what we call it as a sugar baker technique. Now keyhole says, okay, the better way of doing the same thing, not a better way I guess, another way of doing the same thing, if the bowel is protruding out like this, right? So this is where the bowel is protruding out. And this is where the stoma is present. So this is where stoma is present. And this is the rest of the bowel. So the keyhole says, let's install the mesh around this area alone. Right. Now it has completely anchored the mesh around this area, and this is how your keyhole surgery is provided. Again, you are anchoring the mesh to the peritoneum in this particular fashion, and you see it has been completely fixed. This is what we call it as a keyhole surgery. Now what is a resiting one? Now resiting is, this is the site where the stoma was initially created. We now say let's close this area. We're saying let's close this area. We're going to close this area, and let's say we have sutured the entire abdominal wall muscle, we have sutured this part, we have closed this. Now before we open the new site, we'll already push the mesh here. We'll already put the mesh here. Now there are two sides of mesh placements here. So basically we say in this area of the mesh placement, you put it on the abdominal wall itself. So what we do is, we take this subcutaneous layer out and we place the mesh in this area. Above the muscle, I have now placed the mesh. So this is where the mesh is placed. Now I'm creating a new stoma which is going to go through this and open. So now you see the bowel wall is going to go through this. This is the stomal site which is present here. Now what has happened? It is now gone past through this mesh. So there's already a reinforcement that is created around this area, so that through this defect nothing can pass through. This is called as resiting with mesh reinforcement, right? So there are three techniques. In the sugar baker technique, you are anchoring it to the peritoneum with the bowel loop. The some amount of bowel is also taken so that it gets more reinforcement. Keyhole, you're directly putting it. And the last one is resiting with mesh reinforcement. Again, the popular one that is considered a sugar baker, resiting is no longer performed because you are, cause already you have created one defect. Now you're closing and creating another site. So because again the incidence of parastomal hernias are still high, I don't want to take that risk and not be able to create any other site. Okay? So resiting is a poor option because you're creating multiple holes in the abdominal wall, not recommended. So either you go with sugar baker or keyhole. If you give me one option to pick, that is going to be your sugar baker surgery. Okay? So this is all that in the context of parastomal hernia as well. Now, the last thing that we'll be talking about is about the mesh that is going to be used in the hernia. Now, the properties, we'll talk about it. We'll talk about the overlaps and all that. Normally, when we say mesh, no, the materials that is quite oftenly used, one is your Prolene mesh, that is polypropylene. Another one is your polyester mesh, which is more of textile and smooth. And one you have is a composite mesh. It will be using two different materials. So the first image that you have, this is of your standard Prolene mesh. Right? Now you can see it's slightly more thicker. It's like more, like you can see there are a lot of weaves are present. You can see a more weavy pattern, more, it's like more thickened, multi-layered kind of a thing. This is what we call it as polyester, right? So the second one that you have, this is what we call it as a polyester mesh. One advantage of Prolene, it is hydrophobic. It repels water. Polyester is hydrophilic. It likes water. Now, if it attracts more water, it is going to cause more edema, and that is going to act as source of infection. So polyesters are less commonly used, right? Now, this is what we call it as the composite mesh. So as you can see in the composite mesh, we have used two different materials. So the outer one that you can see here, this is your Prolene. And the outer gelatinous membrane, that is, this is your collagen. Right? So inner Prolene is there. So this is your Prolene and this is your collagen material. Okay? So that is about your composite mesh, right? So you have collagen as the outer membrane, inner membrane. And the Prolene will be your outer membrane. So inner is the one that is going to face the abdominal content. The last one is what we call it as the hernia plug. So just, you just plug the cavity. It is a hernia plug. Okay? So when you talk about what are the ideal characteristics, right? So what are the ideal characteristics of the mesh? The ideal characteristic of the mesh. When you look at it, number one, it should be non-absorbable. So Prolene is non-absorbable. Number one, it should be non-absorbable. It should be reactive. That means it should not be biologically inert. It should create tissue reaction. It should be hydrophobic. It should be hydrophobic. It should repel water. It should have large pores. Small pores, it is not going to help. It is going to be macroporous. Now, why do you want macroporous is when you put the mesh, if the pores are bigger and the tissue starts growing into those pores, it will engulf the mesh. The mesh becomes an integral part of the abdominal wall. If the pores are small, the tissues cannot grow inside, so mesh will always remain as mesh. We want the mesh to get integrated into the abdominal wall, and a large pores allow the tissue growth, so hence it gets integrated. So large pore or macroporous is important. And also it should not feel, if you put a mesh, the patient should not feel something is there. It should be lightweight. It should be very lightweight. So it should be of lightweight. So when I say lightweight, it should measure less than 40 grams per meter square. So this is the weight that we recommend as the mesh character. So it should be non-absorbable, it should have tissue reaction, it should be hydrophobic, it should have large pores, and it should be light-weighted, that is less than 40 milligrams per meter square. Now, when you say whenever you put the mesh, there is a mesh overlap. So what is this mesh overlap? It's again a very important concept. Especially when you're putting a Prolene mesh, you should always follow this mesh overlap. Now, what do you mean by this? Let's say this is the defect that is present, right? Now, this is the defect that you wanted to cover up with the mesh, right? Now, when you are putting a mesh, there's something called as an ideal overlap. That means when you put the mesh, you cover the defect in all the areas that are present. So you have put the mesh. Now, mesh is covering this entire area. But if you observe very carefully, I just see I could have only kept the mesh at the site of the defect, but I made sure that it is, covering a wider range or the wider aspect. Now, this is what we call it as the mesh overlap. Now, the question is, what is an ideal overlap and what is a minimal overlap that you have to keep above the defect so that it is a ideal repair. So now you have covered this entire defect with the mesh, right? You have put the mesh here. So we say the ideal overlap is if you measure from this end, that is from the edge of the defect to the edge of the mesh. If you're measuring from the edge of the defect to the edge of the mesh, this is what we called as overlap. If you measure in any particular direction, the ideal overlap is going to be at 5 centimeter. All these has to be 5 centimeters. No matter in whichever direction which you are measuring, this overlap has to be of 5 centimeters. Now, if you are able to achieve a minimum overlap of 5 centimeters and above in all particular direction, this is what we call it as an ideal overlap. So we say the ideal overlap is of 5 centimeters. It should be of 5 centimeters. Now, why you need to have this overlap is we have seen that approximately 50% of the mesh shrinkage is noticed. That means after you've put the mesh, as I told you, the tissue starts to grow in. As the tissue grows in, it crumples the mesh, right? It shrinks the mesh, and that shrinkage is around 50%. So when it shrinks to 50%, it is going to come down to this area. Now, when it comes down to this area, it should be able to have a good amount of overlap. Even if it shrinks by 50%, I am able to cover at least 2.5 centimeters all around. So this is considered to be a good overlapping site out. This is considered to be as a good overlapping site out. So that is why a minimum overlap is 5 centimeters. I mean, ideal overlap is 5 centimeters. If you're not able to achieve that, so what is the minimum overlap? Remember the minimum overlap that you should have. Otherwise, the repair does not stand. It is 2 centimeters. A minimum overlap of 2 centimeters should be managed so that even if it shrinks, a 1 centimeter margin is still left on the defect. So this is to cover this defect. So all that we are doing is to cover this area of defect, right? So just to tell you that what you're talking about, this is the defect. This is the defect that you're covering with this mesh. Okay? So this is all that you should know in the context of mesh as well, right? So this concludes our series on hernia. We have done extensively from the abdominal wall anatomy to different forms of hernias. How do they present? How do we diagnose it? How do we manage it? Every single thing we have discussed it. Do watch all the lectures of hernia. I'll give you the exact set of the lecture points also. So I think we started the hernia lecture somewhere around at 36th episode, and we're concluding this on today's episode. That is our, what is the episode today? This is your 44th episode. Okay? So I want you to go have a look at all these components that we have done in hernia. Any questions, any queries, do write out to us. Next week, we'll start with a new system. As promised, it will be declared earlier. Now, when we deep dive into the system, it is going to be even more amazing. Okay? So stay tuned for the next week. We'll be starting this system. Until then, you know where to reach out to us. Any questions, any queries, you can reach out to the surgery guy. Now, guys, this is my Instagram as well as Telegram. It is by my name. You can get the notes here also. I'll be uploading now only. Right? So any questions, any queries, reach us out here. Until then, thank you so much for joining. Take care. And if you have any questions, any queries, do write us here. Good night. Take care. Bye bye.